with your presentation.
Thank you, Dr. Gaurav. So I would be talking on intraoperative floppy iris syndrome, the long drawn battle. Well, patients using alpha-1 antagonist drugs have predisposition to IFIS, and it doesn't spare any iris, but it is more prone in patients who have blue iris. In this study, as you will find, it is there in Indian irises as well. So there's a triad in IFIS. There is iris billowing, followed by pupillary constriction, progressive, then iris incarcerating, prolapsing into the wound. So there are certain challenges which we have to bear in mind, that there's a reduced maximum pupillary diameter. The change in iris structure is such that the dilator muscle region is thinned out and atrophic, subsequent to which, whenever there is a fluid excess posterior to the iris, there is iris billowing because of the thin and atrophic iris, which can predispose to iris touch. So these patients take a longer time to dilate, and we have to give them the due of taking a longer time to dilate. The stable chamber settings are very mandatory because those will help reduce the fluid access to posterior iris surface. So this is something which we have to bear in mind, that the chambers settings have to be stable so that there is a reduced access of fluid to posterior iris surface. The fluidics which have to be used on the lower side so that there is less of turbulence in the anterior chamber, subsequent to which you have a fluidics in the anterior chamber. We have to decrease the minimum iris touch to minimum because there is an exaggerated response to iris touch. A small iris touch precipitates pupillary constriction because of the unopposed action of the constrictor because of the weak dilator muscle tone. So I'll be presenting a 74-year-old patient using tamsulosin for 14 years. He's a blue-eyed patient with maximum pupillary dilatation around 4.6 millimeter. The technique is that you go in for an anterior long tunnel, because otherwise you can end up with a situation wherein with a short tunnel you are predisposed to an iris prolapse. A calibrated side port incision, a long tunneled incision, is obligatory because at times with a non-calibrated, you can precipitate IFIS. Pharmacomydriasis with epinephrine is usually done, but it is relevant more in early stages where the receptors are blocked, because in advanced stages, there is atrophy of the dilator muscle. So that doesn't affect more when it is a long standing case. In these cases, pupil expansion devices can be used. Viscomydriasis, in this case, I used a viscodispersive to dilate and flatten the iris, the pupil. The ideal is the Arshinov's tri-soft shell technique: viscodispersive, flattening over the iris, visco-cohesive in the center, followed by a BSS solution. So, but we have to be mindful of the fact that if there is overinflation, we can end up with trauma to the iris. So that is another important thing. Capsular rhexis sizing is very important. You should not have a large rhexis for that matter, because by any means, you do not want excess of fluid to the mid-periphery where the dilator muscle is there. So you make a slightly smaller rhexis. Hydrodissection should not be vigorous because that can also cause an iris prolapse. Continuous irrigation, definitely that has to be off. You can see how I put it on off, and while taking out the IA, it still has to be on an off situation, because if you continue with continuous irrigation on, you will have a situation wherein there will be a high ACIOP, which will cause iris prolapse. So that has to be kept in mind while doing this procedure. Next comes the nuclear emulsification. I would like you to focus on this side port incision. You will find that this being calibrated is not allowing large amount of fluid to efflux from the side port incision. So there is no billowing of iris in that region. The next thing which has to be borne in mind is that you have to leave the nuclear pieces in situ. Now, why do we have to leave the nuclear pieces in situ? Because we want to have the bag with the full volume so that the AC is stable and there's a less access of fluid to posterior aspect of iris. This is another important thing which we have to bear in mind. In this, you will find that I'm using higher fluidics. I would suggest that normally you should not be. But if by any means, if the nucleus happens to be hard, there's a trick in doing it. You will see where I'm placing my phaco tip. It is in the proximal half of the pupil, which is farther away from the pupillary margin. So that will not attract the iris by any means. Irrigation, aspiration, bimanual preferred. If you're using a coaxial, retract the iris, retract the sleeve more so that you have two planes. So you see how diligently I'm doing. See the vacuum, how I'm manipulating the vacuum. When I'm behind the iris, the vacuum is low. The plane of irrigation is different. Low vacuum, hold it, bring it to the center and aspirate it. So that is the trick. Our prospective study was done on 105 cases. No patient was asked to stop the oral medication preoperatively. Intraoperatively, IFIS was graded based on iris billowing, pupil reconstriction, and iris prolapse. And in our study, we realized that there was no IFIS in 38 patients and mild in 67, and there was no moderate or severe IFIS. So what was the added thing which we were doing? We were calibrating the side port incision. You will find that we were using a 500 micron outer diameter 25 gauge needle, which was calibrated in size and shape, wherein the distal end of the shaft of the chopper was 400 micron and the proximal was 450 to allow manipulation of the phaco chopper in this calibrated instrument. So this calibrated side port incision is long tunnel, and you will find that it is mostly in 20 to 30%, it is self-sealing. In short, calibrating the side port incision helped in creating a stable chamber environment wherein we did not have excess of fluid to the posterior aspect of the iris. So at the start of the surgery and at the end of the surgery, you will find that there is hardly any difference. So mark my words, trifles make perfection and perfection is no trifle. Thank you very much for your kind attention.